Hello, good morning. First, I want to welcome everyone here from mainly the international speakers and the participants that come from far away. Unfortunately, we're going to be missing 3 to 4 top participants from Israel. They're not going to be able to come, but they were the main organizer for this meeting. So I welcome to the second open expert meeting on the revision of the Declaration of Taipei, convened by the World Medical Association. My name is Carlos Serrano. I serve as the current Director of International Relations of the Brazilian Medical Association, AMB. And it's a great pleasure to welcome you to São Paulo for this important global discussion. My partner here in this opening is Jack Resnick, representing the World Medical Association and former president of the American Medical Association. The Declaration of Taipei is a key ethical framework governing the use of health databases and biobanks beyond research. As you know, it was adopted in 2002 and updated in 2016. It addresses confidentiality, trust, and the protection of sensitive health information. So what we're going to be doing here is part of this new revision since 2016. There are a few meetings that are going to be done worldwide. This is the second meeting for this purpose, and I thank everyone to be here. Also, I want to thank Dr. Nerlan Carvalho. He's Vice President of the Brazilian Medical Association. Our President, Cesar Fernandes, is not able to be here today. I'm not sure where Dr. Nerlan is. Here, okay. You want to sit here with us? And also, Antonio Gonçalves. He's President of the Paulista Medical Association, which is the main association of our national association. And we're here at their headquarters, Paulista. So I'm going to give the word for my partner here in this opening, Dr. Jack Resnick, and thank you everyone for being here.
Thank you, Carlos, and I just want to add my welcome to everyone. So nice to see a number of familiar faces and new faces here at our second open expert meeting as we work to revise the Declaration of Taipei. I want to echo thanks to our host, the Brazilian Medical Association, Carlos, Claudia, the entire team that has made this all happen. To the Paulista Medical Association as well, thank you for hosting us in your lovely building and in this amazing city. And as Carlos mentioned, the IMA, Michelle being the representative here at this point, helping organize all of this as well. So I, as chair of the World Medical Association, I would just say the set of seminal ethical documents, one of which we are here to work on, everything from the Declaration of Geneva through the DOH, the DOT, the ICOME, and others are really at the core of our identity as an organization. We at the World Medical Association do a whole lot of other things, but protecting patients and research participants is really inherently tied to our formation in the wake of the Second World War. I think this topic is particularly timely and critical. The DOT is not as well known as its older sibling, the DOH, but I think the need to figure out how we balance the tremendous potential of big data and AI to advance health on the one hand, with on the other hand, the sort of equally unmeasurable new risks to our patients and their privacy when governments and corporations and others sometimes misuse these new technologies. This is really one of the core issues for our time in 2026. So this meeting is focused particularly on the ethical governance of databases and biobanks amid rapid advancement of those technologies. I will say I am personally here really to listen and learn. We have a lot of experts that we will be hearing from over the next couple of days. We have a number of members of our work group from the WMA who's overseeing this revision, both here in person and some that are listening virtually. And we will be meeting actually right after tomorrow, right after this meeting concludes, to take all this feedback and what we've learned. I will say these regional meetings really end up steering a lot of the work groups that revise these ethical documents. I saw it with the DOH myself. That process also a couple of years ago deeply impressed upon me the critical importance of having these sessions in different places around the world as we absorb the expertise from different regions, the different cultural norms. That really deeply affects this process and is tremendously important. It's also really important that we hear from a diversity of perspectives in each of these locations. So you'll notice over the next couple of days that we will be hearing from physicians and researchers, people who sit on ethics committees, bioethicists, regulators, government officials, people from industry, patient groups, and others. That diversity of perspective is also really important, particularly for a topic like this. So my hope is that if we are successful over the next year or two in this process, in a few years, we will no longer be talking about the DOT as the scrawny little sibling of the DOH, but as a mature member of the family that is well known and regarded in the community, again, because this is such a critical issue of our time. So I welcome you again. Really look forward to hearing from not just our speakers, but the participation of our audience over these next couple of days. And again, thank you so much to our hosts. With that, I think Carlos is going to be introducing our keynote.
Yes, well, actually starting the meeting now, I want to invite Dr. Andrew Spiegel to be our first speaker here for this meeting. Andrew Spiegel has more than 2 decades of experience in the patient advocacy arena. Currently, Dr. Spiegel is in his 10th year as COO of the Global Colon Cancer Association, an umbrella organization of the colorectal bowl cancer organizations worldwide. And he's in the 3rd year as board chair of the World Patients Alliance. And that's why he's here for this role in the Patients Alliance, a global nonprofit umbrella organization of nearly 200 patient groups forms, nearly 115 countries. So thank you very much, Dr. Andrew, for coming here to Sao Paulo.
Thank you very much for your welcoming remarks, and thank everybody for attending. I want to, of course, thank the Brazilian Medical Association, the Israeli Medical Association, and the World Medical Association for inviting me to provide a few comments and to include the patient perspective as this group continues working on this important document. So my name is Andrew Spiegel, and today I'm representing the World Patients Alliance, and we are a global umbrella patient organization working across all disease areas. And these are our 6 board members that started this organization and still remain as board members. We committed to 10 years minimum. I'm now in my 3rd term as board chair, and really excited to introduce to you the organization as well as some of our thoughts on this declaration. So the World Patients Alliance is the world's largest umbrella patient organization working across all diseases. We have more than 730 patient members with about 10 to 20 new applications coming in every month. We are in 140 countries, and as you can see on the bottom, we have a pretty good geographic representation across Europe, the Americas, Africa, Asia, and Australia. And for those that would be interested, our global conference will happen again this year in November in Nairobi, Kenya. So anybody that wants to visit Nairobi, please consider attending our conference November 6th and 7th. But we want to talk about today is this declaration. So what is the starting point for patients? I'm representing patients here today, and for patients, health data is personal. It describes their health, it describes their life, it can help their care, but it also could be hurt. It could hurt them if it's used in the wrong way. So the patients ask, can we trust how our data is being used? And a simple operation when we talk about what patients expect is a simple operating model for ethical data use. And I'm going to talk about these same 4 concepts a number of times here, but clear purpose. Why is our data being used? Who is using the data? And what decisions are being driven by the use of that data? Is there meaningful control? So consent is only real when people can change their minds and still get the same quality of care that they were getting when they gave consent for the data. And are there meaningful controls for privacy? Do we have privacy by design? So minimize the data that's being used, secure the data, and reduce the re-identification risk. And of course, fair value. If commercial entities are benefiting from the data and a value is created, patients and communities should share in those benefits, as well as accountability. Those that are using the data need to be held accountable, and we feel that that accountability should be done by outside people, not by the people using the data itself. So what do patients support when data collection and data use is done properly? Well, a clear purpose. Patients need to know and understand why their data is being used, who has access to the data, and what impact this data will have on treatment decisions. Privacy by design, again, data collection must minimize risk. Ensure information is secure, and challenges to re-identification are addressed. And this really is the main issue when patients talk about data and their privacy. They worry that data will be released and they won't have any control over it, and data is not secure. So we need to make sure that the data is very secure for patients to want to give up their data. Meaningful controls, meaning that the patient should have the ability to pull back their data if they change their mind about consent, without losing access to the necessary health services that were provided as a result of them giving their data. And accountability. So what happens if there is a breach of this agreement, a breach of the consent, and data is released? Is it just a shrug of the shoulders where, well, sorry about that? Or can we hold the people that released it responsible? And can there be transparency? Can there be a complaint process? And so all that should be thought about when looking at patients' data. So who wants to use the health data and for what? The patients recognize that there is value in giving their data, but they also see that there's risks. So let's look at the value first. Care delivery, we know that with data, safer decisions about that particular patient's care can be made. There can be continuity of care and quality improvements as a result of data, and we know all of that. Patients know all of that. Looking at research and innovation, new treatments come as a result of data. Faster learning, faster treatments, and real-world evidence can all come from patients giving access to their data. And often patients will give access not for their own benefit, but for the benefit of the public. And so if there's public health, that's the data is being used for, surveillance, prevention, resource planning. Patients are in favor of that. Very frequently in certain cultures and certain countries, patients are participating in clinical trials and giving data only to help the public, not to help themselves. So that's a very common theme. And again, commercial actors, if there's product development, there's risk scoring, there's market analytics, this data we understand helps drive innovation and helps drive new treatments for patients. So then we have to look at the other side, but what would break a patient's trust with data? Well, that obviously is that data is used without clear information to the patients. Data is used, the purpose is expanded beyond what was originally agreed to. So I agreed to give you my data for this purpose, but those that have the data decided that they're going to use it for other purposes, and I haven't been told about that. Or that I could be re-identified through data linking. So I give you my data for one project, and that project links to another project, or another app, or another cohort, and as a result of that, that de-identification can be re-identified. And data can lead to discrimination and stigma. That is a major hot issue for patients. They're afraid that if I give access to my data, that's going to come back to haunt me someday, whether I go to apply for life insurance and the company knows that I have a disease or something along those lines. People worry that giving that data is going to come back to haunt them at a later time. So that has to be addressed over the next couple of days as well. And there's no clear accountability or remedy if the data is released. So these are the things that patients worry about and things that could be addressed over the next few days to put patients at ease. So at a bare minimum, for the ethical use of patients' data, what do they need? Clear purpose and limits. No open-ended use of my data. Tell me what the purpose is going to be, tell me what it's limited to, and then use it only for that. Clear consent choices in plain, understandable language. And I can't emphasize that enough, that patients across the world do not understand these consents, and if they could be put in a plain language summary in their language, that would be very helpful. Strong privacy and security so that patients know their data is secure and their data will stay private. Independent oversight, not self-approval, so those using the data should be monitored by an outside agency, and I believe the current draft does that. And accountability and remedy if misuse does happen. So what the Declaration of Taipei already does, it already supports patient protections in a number of ways. It has respect for dignity, autonomy, privacy, and confidentiality. It already has rules for valid consent and patient rights. It has rules for governance requiring for databases and biobanks, independent ethical oversights. So the Declaration already has a great starting point, but of course, with innovation and with the changes in technology, what the Declaration needs strengthening, or could use some strengthening, is that patients see new realities, that more health data is created outside of hospitals. So we all know that data used to all come from hospitals, research institutions, and things of that nature, but now I must have 10 apps on my phone that's tracking my data, tracking my health data, sharing my health data, and getting access to my health data. So there's these phone apps, there's wearables, there's digital services, and who knows what's coming down the road. So the Declaration really has to take into account innovation and how data is created outside of traditional hospitals as in the past. Data is now being shared more widely and across borders. So patients should know that their data is being shared more widely, and there should be safeguards in place to make sure that if it is being shared more widely or across borders, that patients are aware that there's transparency that the data is being shared more widely. AI systems can use data at large scales. We know we're just starting to get into AI, and I hope that's going to be discussed a great deal over the next couple of days, because we hear all the time that patients are loading their data into ChatGPT or Google, and they're literally putting their own names and their own identifications out into the public where it will remain forever. And data is shared more widely than ever, and AI systems are using that data at large scale. So patients really need to be made aware of that and how AI can affect data. So data can also be linked with other data sets much more easily today than it used to be, and data sharing happens on a regular basis. So patients need to be protected, and they need